right.
All right. So, oops, I'm gonna stop. All right, so we're going to continue on with spinal cord injury. These beginning slides is connected with the concept mobility. Most of them are identical to, it's not work, except obviously the objectives because it's spinal cord, but the rest of those slides are very similar to the same exact slides that I had for multiple sclerosis and Parkinson's. So again, just mobility, immobility, inability to move. I'm not going to really go into these. Concept of mobility, loss of strength, loss of muscle mass, same exact slides, going from your scope from complete immobility to complete mobility. The people risk factor and where spinal cord is going to fall is this injury in trauma. All right, so again, just neurological, musculoskeletal system, all connected. We had talked about that. And then really the consequence of having a condition like spinal cord where somebody is immobile, you know, from respiratory to skin issues, bowel, bladder, psychological issues all occurring. So yes, the same slide as we had for, again, multiple sclerosis, the health history, your assessment, especially neurological assessment that we would do. So, didn't need to cover all that, so I really want to get right to the exemplar, spinal cord injury. Um, No one else use these, okay. Okay, so spinal cord injury. How many here have worked with patients that have spinal cord injury? So, fair number. Usually the majority do end up with spinal cord injury from some type of trauma. And again, loss of mobility depends if it's cervical level, being what they call quadriplegic, or tetraplegic, you hear the words interchangeable, or, down in the thoracic area, lower paraplegic. But 2-minute A&P, just to refresh. So again, spinal cord injury does affect the spinal column, central nervous system, brain, and spinal nerve. That's the central nervous system. Peripheral nervous system is all the nerves outside of the central nervous system, including autonomic nervous system. So certainly you're going to see issues with central and peripheral nervous system. The brain and spinal column has protection. So the covering layers, the meninges, the dura mater, arachnoid matter, pia mater, and they actually have in the subarachnoid space, the cerebral spinal fluid that helps cushion and protect the brain and the spinal cord. Basic unit of the nervous system, your neuron, where you have the nerve impulses coming into the dendrites to the cell body, down the axon, synapsing over to the next neuron, doing the same thing, synapsing until it hits the end point, which typically muscles move, contraction. In addition to the protective layers, the meninges, you also have the spinal cord protected with these Legos, which is the vertebrae sitting on top of each other to help protect the spinal cord. The problem is the spinal column is at risk because it allows us to turn, bend, rotate. So because it's so flexible, even though it has layers, it has the vertebrae sitting on top, it is at risk for injury. Spinal nerves, again, connecting from the brain and magnum, all the way down. You have your cervical, 8, 12 thoracic, 5 lumbar, and then your tailbone, the the coccygeal area, sacral and coccygeal. So I always remember 8 o'clock breakfast, 12 o'clock lunch, 5 o'clock dinner. That's how it's going down. Injury up in the cervical is quadriplegic, then from T1 down, paraplegic. And again, I'm not testing on the anatomy and physiology. This is just to help as we're going forward. So how do we know what level somebody has an injury in the spinal cord? Certainly x-rays can show me where if there's a vertebrae fracture, we could see, yes indeed, we could see an injury in that area. But basically, all those nerves coming off the spinal column innervate certain areas of the body. So I know that spinal C4 innervates the shoulders. I know C5 innervates, the upper part of the arms. C6, the lower half. So basically, all the C area is quadriplegic, even though sometimes when you get to C6, 7, and 8, they can be independent and they can wheel themselves in a wheelchair. Because you look at C6, they have all the shoulder, they got the upper muscle area, they have all the hands minus the last 2 fingers. When I get to, or actually they have the thumb and the forefinger. When I get to C7, now I have control over the next two fingers. When I get to C8, I have more innervation. So, you know, but it's any part of the upper body that lost some sensory and motor. It's considered a quadriplegic. And then once you hit T1 down, then paraplegic, because you got full upper body strength. But that's how we know, because I know T10 is the belly button. So if I was to have someone come in and they had an injury, we literally have to do sensory and motor. So, you know, can you feel touch, little pinprick going up? And if all of a sudden they can, right above the belly button, I would say that T10, they do not have sensation. And then, you know, I would see, can they move their hand, and can they move any part of their upper body to see if motor and sensory are in the same area. But that's how we know where the injury is. Again, going back to anatomy and physiology, these terms, upper motor neuron, it originates in the cerebral cortex and projects downward. Why is that important? Because you're going to see when I talk about spinal cord, they're either going to have spastic paralysis or flaccid paralysis. Pretty much cervical and thoracic level is going to be spastic paralysis. My lower motor neuron, which is my sacral level and below, originate from the vertebral level and goes out to parts of the body. They have flaccid paralysis. So it does make a difference. Autonomic nervous system, that's my fight or flight. You know, my sympathetic, that's my fight, increased heart rate, increased blood pressure, muscles tighten, vasoconstrict. My parasympathetic, calming, lowers the blood pressure, vasodilate. So those are affected in spinal cord injury that I'll talk about. Because as you can see from this diagram, what happens is sympathetic chains are some areas of spinal cord and parasympathetic up in the brain stem and at the sacral level. So they're different places. But what happens, again, we'll talk about it in a minute, is certain injuries are going to separate the communication between the parasympathetic and the sympathetic nervous system, causing some issues. Reflex arc. So this is, again, remember from A&P saying, oh my God, I remember this little butterfly-looking design, the cross-section of a spinal cord. And what this is typically when sensory input comes in, I see something, I want to move, it goes up to the brain, comes back down, and I do something. But if I'm standing here lecturing to you right now, pouring a cup of tea, pick up the teapot, boiling hot water, and not really paying attention, and it goes onto my hand, I whip my hand back before my brain even knows what happened. Because we have a protective mechanism of a reflex arc, where the sensory comes into the spinal cord, it arcs over, and I whip back my hand, and when I'm whipping back my hand, it's probably then that all of a sudden I realize what happened. But it happens so quick that when I instantly whip my hand back, my brain hasn't even recognized what has happened. So that is also plays a key in spinal cord injury. Function of the spine, again, the last slide for your 2-minute A&P, it really provides structure. Support, allows us upright position, flexibility. Again, it connects shoulder girdle, pelvic girdle, place for our ribs to hang out. So provides a lot of function. All right, so now, why is that all important for spinal cord? So basically, we have the brain that does everything basically that we need to do, all the thought process and everything else. And it uses the spinal cord for sensory to go up, motor to go down. So anything we do, could be lecturing, talking, walking across this room, my brain is constant impulses going up and down the brain. I take a disconnect, it's not going to happen. So I disconnect in a total connection loss between with the motor and sensory. Impulses will not go up. Yes, it will from the upper, so I can still, if it was down here lower, I can still move my upper body, but I can't move my lower body. So that's spinal cord. So definition. According to I think this is the American Spinal Cord Association. Spinal cord injury is damage to the spinal cord that results in a loss of function, such as mobility or sensation. It can be the spinal cord damage, it can be the vertebrae that's damaged, or it can be a combination of both that's damaged. But the motor and sensory issue is going to come if the spinal column is damaged. Currently 10,000 to 20,000 spinal cord injuries each year. I never test on numbers. That you can know. But who's at the greatest risk?
Adolescents.
So it is our males between 16 to 30, because they can actually take motorcycles, jump over cliffs, do a flip and come down into a body of water, and never mind, they're never going to get injured. But that's the daredevil age. This is the reason males have higher insurance than females. So, but they are, they do, for those years, especially teenage into the early adult years, males' insurances are a lot higher than female. But they know that, they're at higher risk. Half of the injuries are a result of motor vehicle accidents, drugs, alcohol playing a role, or just the fact that they could probably want to see the odometer, go up to 120 and for no other reason. But they also tend to be the ones that are more the aggressive sports. Your football, ice hockey, so a lot more, so yes, it could be because of motor vehicle, but there are other reasons for spinal cord injury. 50 to 60% of spinal cord injury is cervical. Why? Because my head can do a lot more than the rest of my thoracic and cervical area. This is the reason your headrest in your car should be halfway up, 3/4 up the base of your head. So you do not end up with a spinal cord, because your airbag deployment is going to do nothing for your spinal cord. So mortality has decreased because now we have airbag deployments everywhere in the car that's helping. We have better equipment for sports, and medical treatment has improved. So people are living a lot longer with spinal cord injury. Again, all the different causes: motor vehicle accident, I already talked about sporting accidents, bullet, stab wound, electrical shock, extreme twisting of the body, landing on the head during a sport injury, or falling from great heights. Yes?
What would extreme twisting of the body, like what would example be?
So somebody who's a gymnastic that goes over what are those called, the horse? It could be a trampoline, but they put their hands and they twist and.
Like the balance beam thing?
Well, what is it?
The ball. Like the ball.
I know that they run, they jump, hands go up, and I don't know what it's called.
So something like that.
Yeah, that they flip over, but they twist a couple times, and so anything like that really causes extreme force when they're twisting. But so risk factors, again, we talked about alcohol, drugs, high risk activities, especially a lot of contact sports, Diving, first rule of dive, feet first at all times, never dive head first time, even if it's in a built-in pool, you always go feet first, so you know what the depth of the pool is. And osteoporosis puts someone at risk. Spinal cord injury in a geriatric patient, they're at risk for falls, just their balance and maybe off, and if they do fall, they're at risk for spinal cord injury just because of the brittle bones, osteoporosis. But mortality for geriatric patient increases if they have a spinal cord injury 65 years and older, so they don't do well. So these are the mechanisms of injury. So hyperflexion, someone falling down the stairs. We have, this is the typical car injury. If you don't have your headrest, the hyperextension causes spinal cord injury. My compression, where your spinal cord becomes like an accordion, that you're diving into the pool, hit the bottom, or you fall off a roof and land on your buttocks. Same type of thing. Your spinal cord actually comes together. Here's someone with a flexion rotation. Also could happen, a flexion rotation, you realized, I left that in the back seat, and you're driving down the highway and you're trying to find it, and then all of a sudden you look back and you get in an accident and you're in a rotation and really that whole twisting movement. If you survive from hanging, you would do damage to the spinal cord, just the weight alone, or penetration gunshot. All those are different mechanisms of injury. So prevention's key. Driving safely, checking the water depth, as I said, feet first, preventing falls, precautions, wearing the appropriate equipment for sports, and no drinking and driving. So here we have Alan Dexter, a 19-year-old college student, was rock climbing when he fell 30 feet to the ground. Paramedics arriving at the scene found him lying in a supine position, unable to move any extremities and complaining of neck pain. He was awake, alert, and oriented to his current location and date of the day of the week, and the details of his fall. His response to questionings were appropriate. He complained that he could not feel his arms and legs. His pupils were equal round, reactive to light. He showed no other signs of injury except for several scrapes on his arms. His vital signs revealed a blood pressure of 110/72, heart rate 82, respirations 18. So what would be key right now at the scene of injury? Stabilization, immobilization, absolutely. We know he's alert, he's oriented, his vital signs are stable, immobilization. I've had spinal cord injury patients, because I've worked with them for years, that diving off the quarry and hit a rock on the bottom, instantly lost, unable to move arms and legs. So he can't swim back to the top. Friends are sitting there watching, saying, why isn't he moving? What game is he playing? And after a while, at some point, friends are going to jump in and pull them out. But that typically will happen if there's an instant spinal cord injury. But the other thing is any high motor vehicle accident, any airbag deployment, any sporting accidents with impact that the neck is twisted, multiple trauma, the assumption is spinal cord even if they can fail. Because it could be a vertebrae is fractured and it didn't sever the spinal cord. But if you continue to move, you could cause the spinal cord to be severed. So the assumption is that it is a spinal cord and immobilization needs to happen. So neck brace, backboard. Anyone have been on a backboard? So a couple people have been on a backboard. You can't move at all. The way they put you into a backboard, you have a neck brace, you have some wedges on your feet so you don't slide down. You end up putting some foam wedges on each side of your head even after you have the cervical collar on. And then you're strapped in with straps around your ankles, straps around your thighs, crisscrossed around the shoulders. So to show that they don't move, there's been many times I've been working with EMTs. Anyone here an EMT? So I've done healthcare camps with EMTs, and we've placed one of the kids in and we just spin them around and around and up and down just to show that they do not move. The kids let us do it, but just to show that they don't move. This situation, you see someone with a helmet. The helmet's going to help keep them neck stabilized, so we don't typically take it off unless they were having great distress. The last group had asked me if they were having respiratory difficulty, what would be the priority? ABCs are always going to take priority, but as a healthcare provider, if someone was laying out, like this case study, Alan laying out supine, I have to recognize that ABCs are a priority, but I got to think, how can I handle ABCs and protect the spine? So instead of doing the neck tilt, I'm going to do a chin thrust to do if I had to do any rescue breathing or CPR. But if they were in a car and all of a sudden the grass was on fire and there was a concern, I'm pulling them out because Good Samaritan's going to help me. I'm not going to worry about immobilization if they're having trouble breathing, they're unresponsive. Either the car's on fire and we're pulling them out, we're working quick. So, but always ABCs come first, but we want to protect that spine. So, for nursing assessments on the spinal cord, one of the things I want to always do, what other injuries do they have? Whether it be a sporting accident, a diving accident, motor vehicle accident. Yes, if the spinal cord's involved, but if they hit their head that caused the spinal cord, do they have a head injury? Is respiratory involved? Because if it's the upper cervical injuries, absolutely, respiratory is an issue. And then trying to figure out motor and sensory, what's going on. Emergency. So they immobilize, stabilize them, bring them to the emergency room pretty much within the first 8 hours to decrease cord edema, IV steroids. Now, you're sitting right in the process of evidence-based. There is probably a third of the emergency rooms out there that have done studies or have looked at studies and said, yeah, you know what, it's not really helping, and they stopped giving IV steroids for spinal cord injury patients. But I'd say there's still 2/3 of the hospital out there that are giving it. And test questions and everything else still say we're giving it. But you in practice will probably see this change. At some point, this may become an old method that comes off. But right now, we're still doing it as soon as possible. And again, it's just trying to prevent any further damage to the spinal cord. Yes, in addition, we're going to look for any other issues going on, hemorrhage, edema, and look to see if, if there's any spinal shock. Spinal shock prevents us from determining the exact level of injury, because if swelling goes on, you may have what looks like a C5 injury, but when the swelling goes down, it may be a T2 injury. So we can't necessarily predict where the injury is until spinal shock subsides. So what is spinal shock? It's a result of swelling in the spinal cord and decreased reflexes and loss of sensation below the level of injury. Because even with a cervical injury, I should still have my Babinski reflex, what you're gonna look and see what's the reflex called? The bubble cavernosus reflex. Those should still be there. But with spinal shock, they're gone. So that's how we know if we have spinal shock. So we gotta wait till the reflexes come back. The other thing is flaccid paralysis. So again, with a upper motor neuron injury, like a cervical, they're more spastic. But if it's all flaccid, it's probably a result of spinal shock going on. It can last days to months. Blood pressure down, heart rate up, like most shocks. And so how do we know it's gone? Bubble cavernosus reflex, we call it the anal wink, because it's the anus that the reflex. You touch around the anus, it actually contracts in. That's what they call it, an anal wink. So we'll have to check quite frequent to see when spinal shock resolves. This is the first reflex that usually comes back. Pulling on the gland of the penis will actually cause the anal wink. Pulling on the clitoris of a female also will cause that anal wink. But we gotta check, because we need to know when spinal shock resolves. Test reasons, for test, reflexes are absent below the level. So, Babinski reflex is absent. That's how you're gonna know spinal shock. Because how are you gonna know the difference between spinal shock and neurogenic shock? Neurogenic shock is damage to the nervous system. And again, a sympathetic nervous system loss results in parasympathetic. But here, this is the one shock where you have hypotension and bradycardia. Most of the shocks you have decreased blood pressure, increased pulse. This one you have bradycardia. But how I would, and then you can see orthostatic hypotension for temperature control. But for you test purposes, spinal shock, loss of reflexes. That's how you're gonna know the difference. And if I was to have a question with neurogenic shock, it would just say, probably I would just say more the vital signs, but I wouldn't just put vital signs without loss of reflexes for spinal shock.
So like paraplegic will still have a Babinski reflex,
Correct? Absolutely.
just not during that first.
Correct. If they have spinal shock, it will be absent. All right, so addition neurological exam, the ASIA scale, American Spinal Cord Association neurological scale, this is where we'll do the pinprick. You would not need to know this, but this is literally a chart that every spinal cord injury unit would use to figure out exactly where they have motor and where they can fail. So we can know which level, because it's not always at the same level. You can have injury sensory somewhere and motor somewhere else. So we have to figure that out. So again, I myself couldn't memorize this chart, but just to know there is a chart that we can determine the level of injury. And then we want to know, is it complete or incomplete? And I'm going to talk about that. So once I know from motor and sensory, after spinal shock is gone, I then can figure out, so if they've lost both motor and injury, and at C6, cervical, quadriplegic. So the cervical, the thoracic, more your back, and then you have your lower back, lumbar, and sacral area. So C1 through 8, quadriplegic, tetraplegic, T5 below paraplegic. All right, so degree of injury. So with spinal cord, it's not so straightforward because you have your whole cross-section of your spinal cord. So if there's injury across the whole thing, it's probably going to be a complete injury, meaning I've lost all motor and sensory below that level of injury. But I can have half the spinal cord injured, I can have the middle of it injured, I can have the front injured, or the back injured. And that could cause all different areas. That's why it's incomplete. So we have 5 different incomplete spinal cord injuries. So this is complete, straightforward, lost all motor and sensory below the level of injury. Incomplete, my first is central cord, where the middle of the spinal cord is damaged, typically infection, tumor, and it typically happens at the cervical level where they have lost motor and sensation of the upper body, but the lower body is fine. So I can walk to the bathroom, but I can't pull my pants down, and I can't wipe myself. I can't feed myself because I have full use of my lower body, but I have no motor or sensory in my upper body. So that's a problem. Anyone ever seen a central cord? I probably have worked with 2 central cords in my life.
I didn't have a central cord, or it wasn't said it was a central cord patient, but on my clinical, we had a patient that could, like, you had spine bifida,
Okay?
and he was all contracted up top. I mean, he was a little contracted on the bottom and the hips too, but he would get out of his wheelchair and walk.
Yep.
Same.
So well, it's not quite the same, but the problem is it's probably allowing, obviously, innervation to go on the outsides of the spinal column, and it's more the center that became an issue. So, and that's why, probably the upper body became problematic, but, and both sides? Yeah.
He was up to all.
So, yeah, so this, like I said, it's been 2 patients that I've had. So you don't see it too often, but a tumor, an infection, because it has to just affect the middle of the spinal column. The other incomplete is what we call brown squat. So this was a little weird because this is half of my spinal cord is damaged. And when half is damaged, so I have an injury on my right side, I lose motor on the side of injury and sensory on the opposite side, because a lot of sensory tracts cross over. And basically, I just want you to know this is that weird one when half of one is gone and half the other. To memorize exactly which side, I'm not going to get that intense. So, so right now, if I had an injury on my right, I've lost my motor. I can feel it though. And my other side, I can't feel it, but I can move it. It's a problem no matter how you look at it, because if you ever sat on your leg to the point that you go to get up because you move it, but you can't, but it fell asleep and you've fallen down, they can't walk. So yes, they may be able to feel it, but part of feeling is knowing where your foot is in space. So if, I can't move it, but I can feel it, or I can feel it but not move it, both cause problem, and they're still paraplegic or quadriplegic, wherever the injury is. The other one is that the front of the spinal cord is damaged. So you think of the front of your car has the motor, front of your spinal cord has the motor tract, and the motor is gone. So you have sensory, but you can't move below the level of injury. I can feel but can't move. Where Posterior is the opposite. You can move but can't feel because most of the sensory is in the back. So again, you can see spinal cord isn't quite as straightforward as one would think. And then we have this horsetail. If you remember looking at anatomy and physiology of the spinal column, that then comes to what looks like this horsetail, leading to conus medullaris and quadra equinus. But the biggest issue here, down when you get down to the lower lumbar and sacral area, is it's lower motor neuron, so flaccid paralysis. But my big issues are bowel and bladder, and we're going to talk about that in a little bit. All right, so if I need to examine someone who's on spinal precautions, how do we move them? Log rolls. So I got to take them all together. But I do need to be able to look to see if there's anything going on. I'm also going to diagnostic testing to see if any injuries. MRI is the best to show spinal cord injury. Surgery may be needed to remove fluid or bone fragments that we need to fuse together. So, Alan, a chest x-ray showed a decreased lung expansion upon inhalation. CAT scan showed cervical spinal injury, so there's a cervical injury. Neurosurgeons immobilized his neck by inserting tongs into the skull above the ears to hold his neck in a position so no further injury could occur. He was then transferred to intensive care and stabilized, then off to a regular floor into rehab. So, halo traction. Has anyone seen a halo traction? This is typical when they're saying cervical injury, a lot of times, halo traction. It's a skeletal traction. Difference between a skeletal traction and a skin is skeletal has bolts that are going into the bone. So this would have 4 screws that are going into the head. And then again, you can see it has a plastic vest. But basically, someone that is cervical traction with a halo vest, the only movement they have, they can walk, but they only can move their eyes, should not be driving. They can't even look into the mirror over here. So they cannot move. I mean, they may be able to walk, but they cannot move. And if you as the nurse were to go in and do pin care and you noticed it was loose, what would your priority be? Call the physician. That must be tightened. It should never be loose. So again, they could have halo traction, or if they just needed a fusion, they may have a cervical collar on. And a lot of times with the cervical collar, they have a dressing underneath it. But the key is if you have to, it's maybe every shift dressing change. They cannot move their neck during the dressing change. So I may leave the front collar on and take the back off so I can do the dressing. Or if I have to take it all off because of the way maybe the dressing is, they had a wound, I'm going to ask someone else to come in and hold the head. But I'm not going to ask them just to hold the head and keep their hands out because I'm going to move. So basically, I ask them to brace themselves on something and hold the head so the head doesn't move. And then I can do the dressing change and put it back on. What's my biggest issue with cervical? Priority with cervical, upper injury. Airway, respiration. So C1, 2, and 3, absolutely vent dependent. 4 and 5, and possibly 6, may need vent support, maybe a CPAP. Definitely need help coughing because they have a weak thoracic area. But see, once you hit to about C7, they're independent. They have, even though they may not have a few areas in the arm, they're independent. But when I get to the thoracic level, again, your legs are affected. Your legs are affected here, but respiration is my big concern. blood pressure. We're gonna talk about some of the blood pressure issues you're gonna have. And then sacral, my big issues are bowel and bladder. So we'll talk about that. So Alan was diagnosed with C5 complete injury, so complete, no sensory or motor below the level of injury at C5. Transfer for rehab for prevention of secondary complications, maximization of physical functioning and reintegration into the community. So, just from immobility, we're gonna have a lot of issues, and now having the spinal cord, we're gonna add more, but UTI, bowel bladder, skin breakdown, pneumonia, DVT, muscle spasm, pain, again, the injury, them not being the same, depression, blood pressure change, because they're with neurological issues, a lot of times you go into more of a vasodilation, so you get up orthostatic hypotension, or we're going to talk about autonomic dysreflexia or hyperreflexia, kidney issues, and all the things with immobility and contractures. So where I'm going to focus right now is these 7 areas. Most of the test questions are coming from this point on, because this is what you need to do. I talked about right now what spinal cord is, so what? Now you need to know you have those issues, what are you going to do? So, impaired mobility. I hate when they fly in separate. All right, so we talked about spinal precautions, and I need to move them. It's log roll. We have to do it in one unit. Again, care of traction, collar splints. And I need to know if the muscles are flaccid or spastic, because if I have a floppy flaccid paralysis and I go to put on a sneaker, I basically can cause all the toes to bend underneath and tie up the sneaker, and they're going to run into a problem. So again, that tends to be my lower injuries. Where if it's spastic, I go to put a sneaker on, all of a sudden, the minute I touch them, they become very spastic, and I can put it on. But spasticity can hurt. So what's our treatment for spasticity? What is it? Medicate. We may have to medicate throughout the day. Some spinal cord injury patients have a baclofen continuous pump, because spasticity can be so bad. But sometimes for me, taking care of patients, a higher injury that has spasticity versus a lower injury, flaccid, I find it's easier when I go to move a spinal cord at a cervical level, all of a sudden they become spastic and their legs just really support. And sometimes I only need one person with a higher injury at times. And then the problem is sometimes I can't get them to sit back down. But where flaccid, I almost have to pick them up and move them in the chair, and I can't do that alone, so would have to use a lift. So knowing, again, if they do have spasticity, how to treat, medication, baclofen's the meta choice, splints, maybe some type of splints, range of motion, and all that. Other thing with immobility, head stockings to prevent thrombophlebitis. If they have a clot, then we're moving to anticoagulation medication. So orthostatic hypotension, a lot of them because of the vasodilation, the loss of elasticity to the blood vessels can cause a sudden drop of blood pressure. So I need to prevent that. Initially, what may happen in rehab is therapy may use a tilt table. So because they'll pass out. So we'll just slowly increase them, bring them back down, 10 minutes today at, with full body, 30 degrees, and hopefully their body will adjust to it. Then I may have to abdominal binder to to try and keep the blood pressure up, elastic stockings to help keep the blood pressure up, and then I may have to have some vasopressors to keep the blood pressure up. But again, blood pressure becomes an issue, especially if we're talking cervical and thoracic area. We may have problems with the blood pressure. I had mentioned our cervical level respiratory is my main concern. See, 1, 2, 3 is vent dependent. But then when you start getting down to the other areas of cervical, they may need assistance, again, because it's not being innervated, so it's just weak muscles in that area. They definitely will need help coughing. You know, to cough and deep breathe, they can't do that. So we do what we call quad coughing, where they'll take a deep breath in, and when they're letting it out, where almost like a Heimlich, pushing in to cause pressure so they can cough. So it'll just help clear the lungs. But again, we do want to make sure that they have good lung expansion, O2 sats are fine, and then we may need support if needed. Skin, a lot of this is fundamentals. They cannot feel. Again, being quadriplegic, paraplegic, biggest area of breakdown is going to be their coccyx area. So change of position frequently, teaching them to change positions frequently. So they have to, even when they get to a point that they're independent in a wheelchair, they have to frequently move in the wheelchair, lean over onto this armrest, lean forward, lean back, and a lot of them will use a watch. Some alarm that will help them remember to keep turning. If lifting up, we don't want to do any sharing, so we don't have breakdown. And if they have TED stockings, and removing them, checking the heels every shift. Increase protein if they do a breakdown. What lab work am I checking for protein? Albumin. So, yep. Why urinary bowel and bladder is an issue. So back when I did the 2-minute anatomy and physiology, what I did is showed you a reflex arc. So sensory, motor. So with, at the S2 to 4 level, we have a reflex arc that helps for urination when a baby is born. So we know infants don't dribble all day. Anyone that's had kids, taken care of kids, they do not dribble all day. Their bladder holds urine and then they urinate. Well, what makes them urinate? What happens as an infant, it's the detrusor muscle stretches. When it stretches to a certain point, it sends sensory impulses, it arcs over, and motor impulses relax the internal and external sphincter, and they urinate. Baby boys, same thing, except for sometimes baby boys, as soon as you take the diaper off and the exposure to cold air stimulates the reflex arc, and they end up urinating as soon as you take the diaper off. So what happens? 2 to 3 years of age, we teach them, the brain, to inhibit this reflex arc, and our brain takes over. So no matter how much, I could have a 6-pack of beer, get caught in traffic, and no matter how much I need to avoid, I'm not going to have an accident. I'm not going to be incontinent. I may have tears coming down my eyes, but I'm not going to be incontinent. Because you know what? My brain has full control over this bladder. And I'm not going to release the internal and external sphincter until I'm sitting on the toilet and I say it's time to go. So what happens if all of a sudden I have a break in the spinal cord And it's an upper motor, oh, this is the upper motor, my cervical thoracic area. What happens is urine goes in the bladder. It stretches, and the bladder is waiting for the brain to tell it to release the internal and external sphincter. But there's a disconnect, it can't. So unfortunately, where would the urine go? Back up to the kidney. That's why they're at risk for kidney issues, because it's gonna go, and it's the pressure becomes so much that the pressure is gonna back up to the kidney and cause kidney issue. So the goal for spinal cord is they need to urinate void under low pressure. So what works? Intermittent catheterization, Foley, that would be we don't wanna go to a Foley, but sometimes we have to go to a Foley, or suprapubic tube if they're having some kidney issues. But upper motor neurons can go all day long and just wheel themselves into the bathroom, straight cath 4 to 6 times a day, into a toilet. They'll just straight cath themselves at home. They could be out and then never wet in between, because their brain's not going to let that internal and external sphincter relax. Where flaccid lower motor neuron, the injury is at the sacral area. And when the injury is here, the reflex arc is like destroyed, and this becomes a flaccid muscle, and they dribble urine all day long. So the detrusor muscle will not hold urine, it just dribble. So Foley cath, suprapubic, or they have to wear a TENS and constantly change it. But the urine will not hold. So this is someone who has most of their whole upper body, because it's a sacral level. They may be able to have braces and walk, but they've lost complete control of their bladder.
So that was the flaccid?
This is the flaccid. So the same thing happens with bowel. Oh, so wait, before I move the urine, so again, we want to make sure we're straight cathing, especially the upper motor neuron, that our residuals are less than 100. Some may need a suprapubic catheter, may need medication to stimulate contraction, or if they're retaining, we didn't straight cath all the way, they could be at risk for infection, and we need to give them an antibiotic. But so the bowel, the same thing. Going back to infants. Infants, feces goes into the colon, the rectum. When it stretches enough, it sends reflex to the reflex arc. The sensory, it arcs over. Motor, it releases the internal and external sphincter of the rectum, and they defecate. 2 to 3 years of age, we inhibit that reflex arc. So the brain takes over the bowels. No matter how bad of a situation, food poisoning, diarrhea, you're not gonna have an accident. You're gonna, again, maybe in pain, but you're gonna make it to a toilet because your brain takes over. Soon as there's a disconnect, there's a problem. With the spastic bowel, stool will go into the rectum. And it's waiting for the brain to release the internal and external sphincter. So the only way we can relax that internal and external sphincter, lubricated glove, teach the patient, and nurses have to do this, go 10 rotations in the rectum to relax the internal and external sphincter. So it'll increase peristalsis and they can have a bowel movement. So an upper motor neuron goes on a set bowel program. And they, again, will almost every day, same time, they'll take laxatives at night and have a bowel program that may take a couple times of what they call rectal stimulation to relax the internal and external sphincter to have a bowel movement, and they can stay continent all day long. where now my injury is lower motor neuron affecting the reflex arc, flaccid muscle. The internal and external sphincter is not going to hold the stool in, so basically they're either going to be incontinent or constipated. We'd rather have them be incontinent because if they're constipated, the only way of getting it out is disimpacting. So a lot of times we want to make sure that we rather keep it soft so that we don't have to disimpact them. So, all right. All right, so other issue, autonomic dysreflexia. There's a disconnect between the sympathetic and parasympathetic nervous system. It happens with injuries about T6 and above. It's life-threatening, so yes, indeed, if you're going to see any question on the NCLEX, it's going to be autonomic dysreflexia. Guaranteed, there's probably at least 2 questions on autonomic dysreflexia on the test. Why? Because it's so important. It's a life-threatening condition. So what happens is there's a noxious stimuli below the level of injury. Noxious stimuli could be a full bladder. It could be constipation. Could be that they have a skin breakdown. Could be that something is sticking into them. They can't feel it. But the body, sympathetic nervous system, again, its injury is only T6 and above. So the sympathetic nervous system says, hey, something's going on, there's something happening. So it vasoconstricts the vessels, blood pressure goes up, pulse goes up, and the upper half of the body, because it's not talking to each other, says, uh-oh, something's wrong. Parasympathetic kicks in, vasodilates, tries to knock the blood pressure down, so they start, because of vasodilation, the ears become bright red, they have a pounding headache, they're starting to sweat, and again, they're trying to get the heart rate down, but the sympathetic system says, we have an emergency going on, so it kicks in even more. Blood pressure can go up as high as 300 systolic. So you can have a blood pressure 300 over 2 something. What's our risk? They can stroke. This is a medical emergency. Spinal cord patients that are at risk for autonomic dysreflexia have a bracelet. They go around with a card because this is life-threatening. So basically, after I assess what the blood pressure is, I recognize it's high. First thing I'm doing, sitting them up. Blood pressure at 300. I cannot have that on their brain. I need to sit them up. I am trying to figure out the cause, but I'm whipping off clothing. If they have abdominal binder on because of orthostatic hypotension, I'm whipping that off, whipping elastic stockings off, and I'm checking for cause. Number 1 cause is a full bladder. So if it's a Foley, I want to check for kink. If they're intermittent cath, I'm screaming for someone to get me a cath because I got to get a cath in there real quick to see if that's the problem. So again, sit up. Actually, I'm going to sit up, check the cause, then I want to, at the same time, whipping things off. If it's, I still haven't found it, my other area may be constipation, but I'm not going to do a rectal check with the blood pressure up so high. At this point now, we're calling the physician, or I have a PRN order that we're going to give blood pressure med to bring this down. Nifedipine tends to be the drug of choice because it's a capsule with liquid in it. So typically we'll ask them to bite until it bursts, or I've actually taken a needle and poked a hole in it and had them bite so the liquid squirts out and they'll bring their blood pressure down quicker. But as soon as you find the cause, the blood pressure comes right down. So again, something that they need to be aware of. So treatment, elevate the head of the bed, check the bladder, check for the cause. remove, check the skin, remove things, and give PRN med to lower it. If you didn't have meds, you would call a physician and then get meds. Yes, indeed, that's on the test. Grief, emotional, again, you tend to be your young males who are very active, someone who played ice hockey, football, on weekends, skiing, and all of a sudden their life has changed instantly. So again, a lot of psychological support, maybe someone who has a spinal cord injury, talking to them about other type of things that they can still be involved in all the sports they did. Now could be wheelchair basketball, regular basketball, but again, a lot of issues, because we don't want them to be so depressed that they're just turning to drugs and alcohol, because that's a route that they can go down. Sexuality, the same type of thing happens with sexuality, like bowel and bladder. Upper motor neuron, males, spasticity, can have an erection and ejaculate. Lower motor neurons, they cannot have an erection and they cannot ejaculate. So again, you talk about someone who can walk almost, but they're incontinent of bowel, incontinent of urine, and they may have to have a penile implant or something else, but they cannot have an erection. Females, the biggest thing is, yes, they can get pregnant, but again, T6 and above, we would never let them go into labor because of autonomic dysreflexia. So, but they can have, they can get pregnant. And again, just when a discharge home, making sure the environment, the ramps that are going up into the house, a lot of them can drive, pretty much anyone from C6 and below, because they have hand function, they can drive. And you hand-controlled cars. All right, so medication, there's very little medication. I'd say the biggest medication, especially for our upper motor neurons, which is most of our spinal cord, cervical, thoracic level, baclofen. All of them, both are going to have some type of stool softener or laxatives, and the rest is as needed. So if they did have a DVT, yes, anticoagulation meds, H2 blocker, prevent stress ulcer, and if they had problems with orthostatic hypotension, we may put them on a vasopressor. But basically, there's not a lot of meds that I would be asking, or with the exception of IV methylprednisone in the emergency room to decrease swelling. So that was probably the other one that I would add here. But basically, you can see there's not a lot of meds for spinal cord. Questions on spinal cord? So, these are questions, but I'm gonna do endocrine right after this because I wanted to do a review. I was gonna plan today to stay and do a review. Because we're over, I wanna leave it optional. I'll start with these questions, but you have the answer. So anyone that can't stay, if you wanna leave, but I'm gonna do these and I'm gonna do endocrine, and everything else I'm gonna do next Monday. That work for people? Otherwise, if we do next Monday, I gotta do more than an hour. That's all I gotta say. Yeah, so I'd say do, so let's go through these questions. Let me read them. Sometimes I don't know why I bring my notes, because I never read. I just wanna catch up to this, all right, so, while in the emergency room, a client with a C8, again, tetraplegic and quadriplegic are used interchangeably, develops a blood pressure of 80/40, pulse 48, respiration 18. The nurse suspects which of the following? So, C is correct. Yes, so autonomic dysreflexia, we would expect blood pressure way up. Hemorrhagic shock, you would expect the blood pressure down, pulse up, and neurogenic is when they both are down. A 22-year-old client with quadriplegic is apprehensive and flushed with a blood pressure of 210/100. heart rate of 50. Which of the following nursing interventions should be done first? We're gonna raise the head of the bed. What did you say?
I said, I didn't even read.
Oh.
Would be.
So I said I could go up as high as 300, but again, 200 is still, pretty high. That's a high blood pressure, probably in autonomic dysreflexia. The first thing we want to do is get the pressure off of the head. So we're always going to raise the head of the bed. Nurse evaluated neurological signs of a male client with spinal shock following spinal cord injury. Which of the following observations by the nurse indicates the spinal shock persists? Positive reflexes, hyperreflexia, inability to elicit Babinski reflex, or reflex emptying of the bladder. C is correct. You lose the reflexes below the level of injury. Your T1 spinal cord injury patient complains of a headache. You should do what? First thing I want to do is take a blood pressure. It's high. Next thing I'm doing is sitting them up. A male client with a spinal cord injury is prone to experiencing autonomic dysreflexia. The nurse will avoid which of the following measures to minimize the risk of reoccurrence? So which one would I do to minimize? So so it's something you don't want to do. So someone said D, I do want to keep them on a strict bowel program. But what I don't want to do is only straight cath twice a day. That's you leaving your house at 7 a.m., urinating, and not urinating again until 7 p.m. That will cause autonomic dysreflexia. So that's the answer. The nurse is preparing to administer an IM injection on a client with spinal cord injury that has resulted in paraplegia. Which of the following muscles best site for injection in this case? So again, they have paralysis and paraplegia, at least I know from probably the waist down. Which one am I going to give an injection? A. So why A? Because they still have use of the arm, and so it's going to absorb much better. A client who was in a motor vehicle accident a few days ago is now complaining of progressive weakness in the arm and upper body while the functioning of the lower limbs is unchanged. Which of the following might the client be experiencing? So this is someone who can walk to the bathroom but can't take the pants down. D is correct. The central cord injury. Center of the spinal cord is injured. A client with a cervical spinal cord injury is being started on a bowel care program. Which of the following should be included in the client's plan of care? So select all that apply. True or false? Place the client on a bedpan every 2 hours. Never, never, never put a spinal cord injury that can't feel their buttocks on a bedpan unless you want a skin breakdown, so no. Keep the client on a fluid restriction. No, I want to increase fluid if they're at risk for constipation. Teach clients to do a Valsalva maneuver to initiate defecation. So a cervical cannot, I have no motor or nerve, they cannot do a Valsalva maneuver. So not even worth trying to teach them to press down and have a bowel movement. Instruct the family to stimulate the anal rectal reflex to initiate defecation? Yes. Place a consult for dietitian to instruct the client in high fiber foods? Yes. Obtain orders from the physician for laxatives and stool softener? Yes. So those last three. A client with a cervical spinal cord injury has demonstrated ineffective airway maintenance. Which of the following can the nurse do to help the client? Select all that apply. So to help them with airway maintenance, always go back and figure out what you're doing. So, insert indwelling urinary catheter. No, it's not going to help urinary maintenance. Teach quad coughing technique. Yes, absolutely. Provide laxatives as prescribed by physician. Nothing to do with airway. Perform chest physiotherapy and postural drainage every 2 to 4 hours. Yes. Keep atropine at the bedside.
No.
No, we don't keep meds at the bedside, never pick that answer. So, provide vasopressor per physician order.
Yes.
Tell me how it affects airway.
JK.
That's why I want to make sure you always go back. If I say true, do true. Vasopressors help airway. So again, try to close that loop with the select all that apply. So no, it does nothing for airway, but it does a lot for the blood pressure. So the only two answers is B and D. A client with a spinal cord injury develops a severe pounding headache. The client is diaphoretic, hypertensive, and bradycardic and complains of nausea and nasal congestion. The nurse determines the client is experiencing autonomic hyperreflexia, or the other name, autonomic dysreflexia. Which action would the nurse take first? What am I doing first? I'm sitting them up. So it's always going to come first. So this slide is really just a summary of everything I said. Basically, C1 through 3 bent from C8 down is pretty independent. C1 through 8 quadriplegic, T1 down is paraplegic. Spinal shock, loss of reflexes, neurogenic shock, blood pressure and heart rate decrease. You have your upper motor neuron and then your lower motor neuron. So again, it just kind of summarizes all in one slide, all the important things that you need to know. But again, most of the questions are coming out of those things on the problems that you would have to do intervention. Again, just another picture for the incompletes. But again, I don't want you to get into all this. As a matter of fact, I probably should get rid of the slide because someone's going to call me and say, they always, this one, that, oh my God, it says the posterior, that I lose some of the sensation, but I keep some. I'm just giving you the easy. No one's going, if you were in a spinal cord injury unit, you'd know this. But you don't need to know it at this level. Motor's the front of the car, upper body central, posterior sensory. Brown's quad is that abnormal one where motor's on one side and sensory's on the other. Period, end of story. This is just for pictures. Ignore all the writing. All right, questions on spinal cord?
What's the prognosis for